Hello. We are going to look at two or three inner ear disturbances. The first one's from chapter 84, and it is vestibular neuritis. One of the reasons I chose to include this acute condition is because the patient is so distraught over the symptoms. So let's just look at it for just a moment. Vestibular neuritis is an acute unilateral labyrinthine dysfunction, also called labyrinthitis. The epidemiology, it's characterized by brief severe vertigo, nausea, vomiting, and disequilibrium lasting a few days, followed by vertigo and disequilibrium with rapid head movement that may last weeks to months. So just those implications of how does that affect your daily life, your occupation, your personal life, and your safety. The pathophysiology, we think that mostly it's caused by viral inflammation of the vestibular nerve. It can be caused by otitis media, so that is an important factor to identify otitis media and treat it appropriately. Associated with the herpes simplex virus type 1 of the vestibular ganglia. An inflamed cranial nerve 8 causes the vertigo and may be caused by irritation of chemical products associated with acute or chronic OM. So what's the clinical presentation? Again, complaint of severe vertigo, nausea, vomiting, aggravated by turning of the head. Tinnitus is present usually, but the hearing is intact. That's a diagnostic clue. Vertigo lasts for 2 to 5 days. Most cases resolve spontaneously, but a few cases last for months, and that's very distressing to patients. The history should include meds, head trauma, or recent infections. So on the physical exam, you're going to do a thorough ear, nose, throat with neuro exam and go ahead and include the Romberg. Hearing test, you should anticipate that it would be normal, but what if their baseline wasn't normal? So keep that in mind when you question about that. Diagnostically, the definitive test exam to test hearing and assess vertigo. If bacteria is suspected, you want to obtain a CBC with a differential, and if any reason to suspect tumor, then an MRI or a CT. Management, you have 3 goals, primary goals. Alleviate vertigo, nausea, and vomiting. 2, treat an underlying infection if it exists. And 3, improve ventral compensation with vestibular exercises. So we can use anticholinergics, antihistamines, benzodiazepines, and antiemetics. Meclizine is usually a choice, 25 milligrams every 6 hours in pregnancy, and that's an antihistamine. And then we could also consider steroid therapy, but the evidence isn't real strong of its effectiveness. Referrals, if your diagnosis is unclear, or if the infection's severe or symptoms don't resolve in 4 to 6 weeks, we definitely need to consult an otolaryngologist. Associated suppurative or meningitis necessitates a referral, which makes sense. Dehydration requires IV fluids and possible hospitalization. Again, I can't reiterate how distraught these patients are, so just really a thorough history and exam is imperative. Patient education and health promotion about that disease and reassurance that it usually spontaneously resolves. Discuss the need to slowly change positions and not move their head rapidly to provoke any of these symptoms. And they are to report any increase in severity, because then your differentials would expand out. And the patient should also expect for this to resolve within 4 to 6 weeks. Thank you.